Protection Committee, March 11th, 2025. We don't quite have a quorum yet. I will announce when we do. We're going to change the order of the agenda in recognition of that and start with Senate File 1910, Senator Oumou Verbeten.
Thank you,
Senator
Mr.
Oumou
Chair.
Verbeten, welcome to the committee.
I do have an author's amendment to the bill, Mr. Chair.
Senator Oumou Verbeten, why don't we hold off on that till we have one more person here at the table, and go ahead and tell us
Okay.
about your bill.
Thank you so much, Mr. Chair.
We are at the quorum. Members, we have a quorum. Senator Wickland offers the A1 author's amendment. All those in favor say aye. Aye. Opposed? Amendment is adopted. Senator Oumou Verbeten.
Thank you. This bill is really about ensuring the basic well-being and safety of attendees at entertainment venues in Minnesota. Access to water is a necessity, especially in crowded, high-energy environments like concerts and festivals. And this bill is really a common-sense measure that aligns with public health priorities and consumer fairness. What the bill does is it requires venues to provide access to free water at events. They can do it in 3 ways. So many venues already provide water on site. They could allow attendees to bring in bottled water or allow folks to bring in empty water bottles and then provide filling stations on site. So really ensures that there's one reasonable way for people to stay hydrated at these events. And we know that dehydration and heat exhaustion are real risks at entertainment events, especially in large indoor or outdoor venues with limited airflow. The lack of free water can create unsafe conditions for attendees, leading to preventable medical emergencies. Many venues do prohibit outside water and then charge these really high prices for bottled water. So it's effectively forcing people to choose between hydration and affordability. So I do have some testifiers who can speak to this a little bit more today, but I have included in your packets an article from the Minnesota Daily that talks about the necessity of free water at concerts. I also would highlight that there are some artists who have been proactively addressing the issue. Billie Eilish at a recent tour had encouraged folks to bring an empty water bottle. In the UK, licensed venues are mandated to provide free drinking water upon request. And then, as I mentioned, there are a number of Minnesota venues that do this already. So, for example, Excel Energy allows guests to bring a reusable water bottle into the venue upon inspection. All venues by First Ave have free accessible water. And Minnesota United allows fans to bring in transparent plastic water bottles, and then they have those refilling stations on site. So really just looking to make sure those options are available to folks at any of these venues. I think this is really practical and fair, and it's necessary, again, to protect public health and ensure that all Minnesotans can safely enjoy concerts and events. This would also make Minnesota a leader in consumer-friendly event policies. And it really does offer those flexibilities for venues while ensuring no one has risk of dehydration or is having to pay these excessive prices just to stay safe. And I do want to add that in the amendment that we adopted, there's just that flexibility for venues. If they need to limit the type or the size of the water bottle in order to protect the safety of others, and that's just been a result of some feedback from venues. So with that, I'd love to move to testifiers, Mr. Chair.
Thank you, Senator Oumou Verbeten, and I'll have the clerk correct the record that we voted on the A2 author's amendment and approved that. And now we'll go to Audrey Stenzel and Eleanor Anderson. Please come forward. Ms. Stenzel, welcome to the committee. Please introduce yourself and proceed.
Hi, everyone. My name is Audrey Stenzel. Okay. My name is Audrey Stenzel. I'm a 15-year-old from Shoreview, Minnesota, and I'm a student at Mounds View High School. But today, I'm not only here as a student, but as a concert goer, performer, and a musician. I'm honored to share my experiences in support of Senate File 1910, a bill that would require concert venues to provide potable water at events. Growing up, music has become a huge part of my life. I was strongly influenced by my mom, who always had music playing in every room in the house, and if there wasn't music playing, we were probably singing. I learned to sing and play a number of instruments, and though it's early in my career, I'm a very successful solo performer, and it's a huge part of who I am. For many of us, music is where we find safety and comfort in our chaotic world, so what happens when that safety becomes unavailable and even dangerous? I would like to share an experience with you all. In August 2023, I went to my first concert without my parents. It was on one of the hottest days of the year, and I brought a clear, empty water bottle prepared to refill it, but once I got to the gate, the venue wouldn't allow it. Within an hour of getting to my spot in general admission, I was on the floor, dizzy and anxious, and I was asking for my own bottle of water, but I was required to share with others. At the risk of heat exhaustion, I continued to take small sips and pass the bottles back. Consumers have a fundamental right access to water, especially in condensed environments where we are exposed to extreme heat and physical activity. Not having access to basic hydration is a direct threat to our health and safety, and I believe it's essential for venues to respect and protect that right. On the other side, I've lived through experiences like this as a performer. My gigs are very frequently at community farmers markets and other outdoor venues. I've learned that risking my health can arise quickly in the summer. While I always plan ahead and I bring my own water, those hot days it goes fast and there's often nowhere to refill it, or I have to risk leaving my equipment unsupervised. I've had to leave several performances early due to dehydration and heat exhaustion, and water should not be a luxury, especially for those working in such warm conditions. We're not asking for every venue to give out free water bottles, which I understand would be costly. It's something simple, allowing attendees to bring an empty, clear water bottle into the venue. According to the World Health Organization, heat-related deaths have the highest death count of weather-related deaths, surpassing tornadoes, floods, and rip currents. With our climate continuing to heat up, this will only get worse, and this small change can transform the experience of performers and concertgoers alike. We shouldn't have to worry about our health when attending summer events, and it's heartbreaking for me as a young performer building my career to have to cancel or leave a gig due to concerns about hydration. Even when water is available, I've had to pay over $10 for a small, non-refillable cup. Going home with a headache is not how I want to remember my concert and performance experiences, and if I'm exhausted, I want it to be from having fun and dancing and not dehydration. All Minnesotans deserve to feel safe and hydrated at our events, and I urge you to vote yes on Senate File 1910 to protect all of our Minnesota consumers. Thank you.
Thank you, Ms. Stenzel. Could you make room for Joel Carlson? Ms. Anderson, please introduce yourself and proceed.
Chair Klein and members of the committee, my name is Eleanor Anderson. I'm a junior studying political science and economics at St. Catherine University, and I'm an avid concert goer. My love for live music started in April 2022 when I got last-minute tickets to see Olivia Rodrigo's Sour Tour. Rodrigo's audience, for those who are unfamiliar, consists of mainly girls between the ages of 12 and 20. So when my friend and I decided to go to our first general admission show on our own at 17, we weren't too concerned for our safety in this crowd. Picture this. The opener is playing and people are still filtering into the armory, but dedicated fans have packed the front of the standing room after waiting outside for sometimes more than 12 hours. The crowd is hot and starting to get antsy, waiting for Rodrigo to come out. Suddenly, someone collapses. Then, between the opener and main act, another person goes down. The armory was sold out and security was passing out water, but it never made it past the first few rows of the pit. Meanwhile, my friend and I had thrown our water bottles away while going through security because we were told they weren't allowed in the venue. People kept going down, and Rodrigo alone ended up pausing her set 5 times so that security could evacuate people who passed out. Mind you, this wasn't a hardcore rock crowd. We were singing ballads about teenage breakups, high school drama, and driver's licenses. My friend and I were lucky that we both made it through, but neither of us realized this experience didn't have to be normal. I've been to almost 20 concerts since, and I continue to compare the number of people who pass out from dehydration and heat exhaustion to that first experience. I've yet to be at a show that hasn't had some kind of incident like this. For students at concerts, where tickets and parking fees alone are enough to break the bank, Paying steep prices for a bottle of water feels like a slap in the face. We can be naive enough to think we can make it through the event without paying for water, and stubborn enough to push our limits trying. However, no one should need to put their health and well-being at risk because of an undue burden of accessing water. This bill would address an issue that should be largely unopposed. Water should be freely available at concerts. And some venues are already trying to make this happen, but it isn't enough. As we've seen, dehydration can be life-threatening. Last summer, a young woman died outside of a Taylor Swift concert from heat exhaustion. And I don't want to have to keep risking my health and safety every time I think about seeing a show. Now is the time for legislative leaders to protect the people of Minnesota and encourage healthy decisions and participation in live music. Thank you.
Thank you, Ms. Anderson. Ms. Stenzel, can you give your seat to Mr. Carlson, please? Thank you. Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair and members. Joel Carlson. I own a legal research and government affairs business here in St. Paul, and am here on behalf of several clients that I represent, but mostly Minnesota United, the professional soccer team, and as the most current stadium that was brought online in 2019, designed for both sustainability and the fan experience. So I appreciate the A2 amendment and having the chance to talk with Senator Oumou Verbeten about this bill. No opposition to the bill, but it is a matter of clarity and consistency. One of the things that venues are concerned about, or my venue is concerned about, is bringing in a filled bottle of any kind. Whether it's factory sealed or not. We don't know what's in that bottle, and allowing that, well, it's an option. If someone says, hey, I have a legal right to bring this in, we don't have clarity in the law. Our stated policy on our website and many other venues as well allow for a empty plastic transparent bottle to be brought in, and they provide free water. And there are concerns about bringing metal water bottles that I'd at least like to put on the table, and have expressed that to the author. So we think consistency is important. Providing the free water, yes. Allowing someone in to bring a clear and transparent plastic bottle that can be refilled at no cost, we think is good public policy. While options are always a great thing, in this instance, we may be setting up a fan conflict situation with people coming into the venue that say, I have a right to bring this in, and while you're screening, 30,000 people going through the gate, that is really a challenge. And so, we support this effort, but want to make sure we have clarity and consistency across venues. So happy to answer questions, Mr. Chairman, as this continues to move through and work with the senator on proper language. Thank you.
Thank you, Mr. Carlson. We're always very grateful at this committee when we have Senator Oumou Verbeten here, because she works with opponents and advocates on all sides and sort of comes to the committee with a finished product. And if I understood you, Mr. Carlson, correctly, just have you come back briefly. With the A2 amendment, you feel that the concerns of Minnesota United are answered, and you are supportive of the bill?
Mr. Chairman and members, the A2 amendment does correct, it does fix a number of the issues that we had brought to the senator's attention, like the free bottled water, which is, we're trying to reduce those, not increase them. That took that out. It still allows for sealed, filled bottles to come in of any variety, and that is on the amendment on page, or on line 1.8. And then as it relates to the empty water bottle, it just lacks clarity, we think, as it relates to plastic and transparent. So that part wasn't changed on the A2 amendment. On line 1.17 and 1.18, that definition of a water bottle just is wide open right now. It could be any type of bottle, metal. You can see 6 different ones sitting at the committee table right now. And we just want to make sure there's consistency, which we're not quite there on the definition.
I'll go to Senator Oumou Verbeten, but I would just point out from my reading of the bill with the, as amended, Minnesota United and all other venues would have 3 different options. You could either just provide water yourself, you could allow a water bottle in, but if you didn't want to, you had 2 more options you could offer. Senator Oumou Verbeten, any response? Or?
Yeah, thank you, Mr. Chair, and thank you, Mr. Carlson, for the feedback. It was all very helpful. I think my goal is to ensure there's flexibility for all of these venues. While I completely understand their concerns around bringing in bottled water, that doesn't work for that venue. It may work for another venue, and so I think leaving that in is helpful, but would love to hear the committee's thoughts on that. The way it is structured, there are options. So Minnesota United could have water on site or allow folks to bring in empty bottles. And I did add the language that clarifies they have the ability to limit the types or sizes of water bottles in order to protect the safety of others. I know there's a concern about metal containers that could be, used to injure others, and want to give venues that flexibility on the type of empty bottle that comes in if it's a concern.
Members, questions or comments for the author? Senator Howe.
Well, thank you, Mr. Chair. And I think the amendment does help a lot. But I will just want to say that if even just an empty plastic, just a water bottle like Dasani or any of that is full and you get it thrown and hit you, I tell you what, it leaves a mark. And I think that is the concern. So, and especially if you have one of those 1.5 liters or something to that effect, I can see why some entertainment venues might have an issue with that. So I think the amendment does address some of that. So I think that the types and sizes, I think is a step in the right direction. The question would be is if it's totally up to the definition of the venue, I think that goes a long way. But I just want to reiterate the concern that, the folks that some of us have been on the front line of getting hit with some of those, they can leave a mark and do damage. So that's the concern I have. And the amendment goes a long ways to get there. I just don't know if it goes far enough.
Thanks, Senator Howell. Yeah, we've all seen the YouTube videos of artists that are being targeted by projectiles. So Senator Seeberger.
Thank you, Mr. Chair. I completely agree with the intent of this bill to provide free and free access to water at events where there are concerns for dehydration and overheating. I think a concern that we haven't touched on and which two of your testifiers talked about was general admission. And having worked as a medical provider at the XL Center for the last 10 years, I've been to plenty of concerts where I'm the paramedic on call, I'm the out in the crowd assisting with the crowd when there's 5,000, 7,000, 10,000, 15,000 people there. And one of your testifiers said that I think it was at the Olivia Rodrigo concert, security was passing out water, but it didn't make it to them. The problem really lies with general admission. These kids stand in line for hours before they get into the venue. Then they get into the venue and they get up front and they don't want to move because they're going to lose their spot. So even if there is free water, they can't access it. At the XL, I know we have water in the aid room when it's a GI show and there's going to be a lot of kids on the floor. We have water set up next to the stage. We have water in a lot of different places. I don't work for the XL, but I'm there. And in charge of keeping an eye out for folks that are dehydrated. So I think if the intent of this bill is to ensure that people have access to water without having to buy a bottle of water, I completely support that. But I do think, and now's not the time, but I do think we have to take into consideration the role that general admission shows play into injury and unfortunately death when it comes to young people that maybe don't listen to their limits. So I just throw that out there. I guess I also share the concerns with bringing in a full bottle of anything, having seen, again, just the sheer amount of patrons who stream through the doors and who oftentimes pregame pretty heavily while they're in line and could find ways to smuggle alcohol or other non-water substances in a seemingly sealed container. So those would be my concerns. But again, I do support the intent of this bill, and I hope we can get it in a form that we can get it through. Thanks.
Any other comments or questions from the committee? Senate File 1910 as amended will be laid over for possible inclusion. Thank you, Senator Oumou Verbeten. Turn now to the start of the agenda. Senate File 1806. Welcome back to the committee, Senator Mann. Senate File 1806 is in front of us.
Thank you, Mr. Chair and members. So Senate File 1806 exists because I'm tired of getting phone calls from patients that go like this. Dr. Mann, I'm at the pharmacy and I'm getting told that I can't get my medications. I told them that I've been on these medications for 6 years and they said that my formulary changed and I can't have my meds anymore. What do I do? Senate File 1806 also exists because I'm tired of being at the emergency room where a patient comes in and says, I'm here in the emergency room because I couldn't get my medications on Friday, and the pharmacist told me that my meds were no longer available to me, and I couldn't see my doctor over the weekend, and now my blood pressure is 200 over 112, and I don't know what to do. These are very real patient encounters that occur regularly. And so Senate File 1806 says that you can change your formulary whenever you want, as often as your heart desires, but if a patient is on a medication, they can stay on that one medication until the end of the year, and then you can switch them off of it. It is not a formulary freeze. It is a patient protection issue. We cannot pull the rug out from under patients anymore and then expect good patient healthcare outcomes. That's it.
Thank you, Senator Mann. We'll go to your testifiers. I forgot that you do have an author's amendment on this bill. And so Senator Seeberger offers the A1 as an author's amendment. All those in favor say aye. Aye. Opposed? Amendment is adopted. Members, I think this bill and the two other Mann bills are waiting fiscal notes. They won't be here for the benefit of this committee. Apologies. All of them will be hopefully passed on to Health and Human Services where those notes will be available, and the bills will be carried in the budget of the HHS committee. With that, we'll go to your testifiers. Start with Dr. Verbeten. Welcome to the committee, Doctor. Please introduce yourself and proceed.
Thank you, Chair Klein and members of the committee. I'm very happy to be here. My name is Dr. Roly Verbeten, a family medicine doc, and I'm the president of the Minnesota Academy of Family Physicians, representing more than 3,100 members across the state. I'm testifying today in support of Senate File 1806 on behalf of the Minnesota Medical Association and the Minnesota Academy of Family Physicians. I'm a family physician and the CEO of Community University Healthcare Center, taking care of the patients in the East Phillips neighborhood in Minneapolis. SF 1806 restriction of mid-year formulary changes will make a big impact on our patients and their life and the healthcare teams. The unacceptable disruption to care caused by these changes is frustrating for both patients and the physicians. For many patients, but especially those with chronic conditions, finding a medication that works for them is really, really difficult and time-consuming and may take extensive consultation with their physician. My patients utilizing an inhaler to treat their asthma or a medication to manage their depression deserve steady access to that care to allow them to live their healthiest lives. I'm going to share a true story that happened last week. One of my patients, Sam, who speaks Laotian, had finally found stability. After years of struggling with uncontrolled diabetes, we had found a regimen that worked, not just clinically, but in her life as well. It kept her blood sugar levels steady, had minimal side effects, was easy to take, and most importantly, she could afford her, and it was covered by her insurance. For the first time in years, someone felt in control of her health. Then later year, she walked into her pharmacy to pick up her refill, only to be met with the confusion. The pharmacist informs her, your insurance no longer covers this medication. You will either need to pay out of pocket or talk to your doctor about switching to another medicine. She knew that what meant. The alternative might not work as well. It might cause side effect that made her tired, or it can make her sick, or worst of all, she might have to go throughout the week of appeal and the paperwork before she could even get that medication. The next few weeks were a blur of phone calls, waiting on a hold, and frustration. I finally submitted a prior authorization request, but it was denied. The insurance wanted her to try a different older medication first. Within days of switching, her blood sugar spiked. She felt exhausted, dizzy, and worried about her health and about being a burden to her family. By the time her appeal was finally approved, Sam Wang had already experienced a trip to the emergency room for a dangerously high blood sugar level. A change that had seemed small on paper, a mid-year formulary update, had nearly unraveled the progress she had worked so hard to achieve. For patients like Sam, a formulary change isn't just policy update. It's a disruption that can mean the difference between stability and crisis. It's a reminder that behind every medication decision is a person trying their best to stay well. And it's also a really big cause for the frustration for the clinicians. Doing so much paperwork, I broke her trust as well. A lot of our patients, they think that the medications decisions are taken by the clinicians. And when we make a change, it just breaks the trust as well. Insurers and the PBMs use formularies because of the high cost of medications, yet mid-year changes are harming their patient care. This legislation would not prohibit all mid-year formulary changes. It would only limit changes if a patient is on a drug that is working. Because patients cannot change their insurer in the middle of their contract year, insurers should not be able to force patients to change needed drugs until the contract years has expired. This balanced approach allows patients to continue having access to their successful treatment without prohibiting PBMs and insurers from changing formularies for all other enrollees. Forcing patients to change from the medication that is working is not what is best for the patient. Mid-year formulary changes cause patients to lose access to their life-saving medications, despite not being able to change insurers until the end of the enrollment year. Physicians across the state urge to support SF 1806 as an important step to help protect Minnesotans. Thank you again, Mr. Chair and committee members, for giving me this opportunity and bringing our patient and our voices here. Thank you.
Thank you, Doctor. Can Sue Abderholden and Joe Selwood come forward? Welcome to the committee, Ms. Abderholden. Please introduce yourself.
Thank you, Mr. Chairman, members. Sue Abderholden, Executive Director of NAMI Minnesota, National Alliance on Mental Illness. On behalf of NAMI, I'm testifying in support of Senate File 1806. To be honest, it feels a little like deja vu. I can't even count the number of times we have testified to the negative impact of a plan making changes to the drug formulary, benefits, provider network, et cetera, in the middle of the plan year. It is extremely disruptive to people's treatment and their wellness. People with mental illnesses often find it takes several different trials of medications to actually find the ones that work. And once you find what works, you don't want to make changes. My late husband had serious depression, and once we found kind of the right mixture of medications, I think I would lay down in front of a train to stop any changes to that. People frankly fear that if you have to change medications and not on the recommendation of your prescriber, the symptoms will return, such as devastating depression, being overcome with anxiety, experiencing mania, or hearing voices. And we're not talking about simply an inconvenience. We are talking about symptoms that can disrupt your life, your job, your education, your relationships. Thus, many people with mental illnesses who are choosing a health plan look to see if their provider is in network and if their medications are in the formulary and what their co-payments would be. They choose a health plan based on these factors. I've been through it numerous times with my own family members. To have a health plan change the formulary or the cost during the plan year is what I would call bait and switch. People have chosen that plan because they can access their medications they need and the providers they like. People pay to have a plan that meets their needs. Making changes in the middle of a plan year simply isn't right and causes great problems for people. It means they have to go back to their prescriber to find a different medication, which frankly can take months to secure an appointment, especially with a mental health prescriber, or pay more for a medication, which frankly isn't always possible. It's really not fair for a health plan to say you can't keep your medication after you've chosen them. Please hold them accountable for the plan they offer to people. I urge your support for this bill.
Thank you, Ms. Abderholden. Can you make room for Dan Andreessen? Mr. Selwood, please introduce yourself.
Mr. Chair, members of the committee, my name is Joe Selwood, and I'm testifying on behalf of the Association for Accessible Medicines, the leading trade association for manufacturers of the generic and biosimilar prescription drugs that saved Minnesota and its patients $6.2 billion in 2023 alone. As currently written, this bill allows health plans to make formulary changes when replacing a brand-name drug with a biologic drug rated as interchangeable. This does not include lower-cost biosimilars. As the bill progresses, AAM would encourage and request that biosimilars be added to the exceptions in paragraph C for the following reasons. First, biologics now account for approximately 45% of prescription drug spending in the United States. This disproportionate spending underscores the urgent need for more affordable alternatives through competition. Second, the FDA has consistently affirmed that approved biosimilars meet the same rigorous standards as their reference biologics. In fact, the FDA recently issued draft guidance on interchangeability, stating that healthcare professionals and patients can be confident in the safety and effectiveness of a biosimilar product, whether or not it has also been approved as an interchangeable biosimilar, just as they would for the reference product. And third, in the next decade, approximately 90% of biologics will lose their patent protection, creating unprecedented opportunities for biosimilar competition. By adding biosimilars, Minnesota can position itself to fully benefit from these savings by ensuring our laws don't inadvertently create barriers to biosimilar adoption. Thank you for the opportunity to speak, and I'm happy to answer any questions.
Thank you, Mr. Selwood. Stick around. Mr. Andreessen, please introduce yourself and proceed.
Mr. Chair, members of the committee, Dan Andreessen with the Minnesota Council of Health Plans, representing nonprofit insurers here in Minnesota. The healthcare system is not perfect and it's not simple, and that's definitely the case when it comes to pharmaceuticals. Prescription drugs are life-changing and often life-saving. However, the cost of prescription drugs now exceeds the cost of inpatient hospitalization. Drug manufacturers set the price of the drugs they manufacture and sell, and as a for-profit company, they seek to maximize their profits. Health plans are tasked with trying to manage these extremely high costs so enrollees have access to needed and cost-effective medications. The challenge with the legislation being considered today is that it enacts new regulations on health plans when the root cause of the concern is the enormous price of prescription drugs set by drug manufacturers. Regarding Senate File 1806, our nonprofit plans try to strive to make as few changes to the formulary throughout a plan year. We want consistency during that year. While some of the exceptions to the bill generally reflect current health plan practices, there are also times when a drug manufacturer arbitrarily increases their price in the middle of the year. And health plans have few mechanisms to financially protect all of our enrollees. Some of that instability is already built into premiums, but we're also trying to keep our premiums low. And taking away the ability to manage a formulary in these situations can result in everyone paying more in the future. I've spoken to my member plans, and it is rare that our members make this type of change in the fully insured market, the only commercial market that this requirement will fall. The self-insured market is not subject to the requirement, and some of these situations might be happening in that area. A similar bill was debated in the last biennium and included language requiring drug manufacturers to freeze their prices throughout the year, eliminating the need for a health plan to make formulary changes because of any price increases. This language is not included in Senate File 1806, and we would urge its addition, and if so, the council would be neutral on the bill. Do want to thank Senator Mann for adding in the language regarding extending the regulations to state public programs. We have a standing position that any requirement that is on the commercial market should be equally applied to state public programs. And then, Mr. Chair, do you want me to continue?
Mr. Andreessen, while you're here, if you want to go ahead and comment on 1876 and 1877, thank you.
Okay. Thank you, Mr. Chair. The other bills before the committee are regarding drug rebates. Senate File 1876 would require plans to prioritize on its formulary the drug with the lowest price at a moment in time. However, the drug with the lowest price is not necessarily always the lowest cost to the enrollee. So for example, let's say you have two drugs, drugs A and B. One has a price of $100, the other one has a list price of $150. They're completely equivalent medications. However, the manufacturer of drug B provides a $60 rebate to their drug, which lowers the cost to $90. As a health plan, we're going to go with the one that's the lowest net cost to our members. And that's because once we add in that lowest net cost, everyone's paying less healthcare costs for that drug. Health plans pursue drugs with the lowest net cost for Minnesotans over the whole year and in consideration of all costs, not necessarily a drug in time. Under Senate File 1876, health plans would be restricted on their lowest net cost efforts, and enrollees could actually be paying more over time. Regarding Senate File 1877, which would require all rebates for specific drugs to apply to the cost sharing to the person actually using that drug, the rebates collected by health plans are used to lower the healthcare costs for everyone in a policy. Just like we spread out the risk, we also try to spread out the benefit for everyone. We have concerns about point-of-sale rebates because of the impacts to all enrollees as well as administrative costs to apply these rebates per person. Instead of targeted rebates, pharmaceutical companies should just simply lower their prices. Now, drug rebates have become a growing topic of conversation here in Minnesota and nationally, and we share the concerns about the trajectory of their use and the impact on the healthcare system and patients. Drug rebates are a marketing scheme used by drug manufacturers to manipulate competition and increase the sale, market share, and revenue of their drugs. It's a program that may have had good intentions at some point, but has now been abused by companies to generate enormous profits and push lower cost alternatives out of the way. We're often faced with the impression that we support rebates, but we didn't create rebates. It resulted from a legal dispute between drug manufacturers and pharmacists, but we do want to lower costs. And if rebates are part of the system and they can be used to lower the cost, the net cost for our enrollees, we're going to use them. And if they're going to be part of the system and we can't, then enrollees are going to be paying more. It's a system that we must operate in and continue to do so until someone changes the rebate system. Ultimately, the proposals before you seek to lower costs, and we agree that with that goal, but these bills will fall short because the pressure is not on the drug companies who set the price. Instead, the proposals hinder health plans who are trying to lower them. As a reminder, health plans are the only entity in the healthcare system that is subject to a medical loss ratio, meaning that our margins are essentially capped. No other healthcare entity has this requirement. We need policies which require drug manufacturers to face real competition and price pressure that moves the cost curve downward, and we'll be happy to partner with Senator Mann or anyone of the committee to do so. Thank you, Mr. Chair.
Thanks for consolidating your remarks, Mr. Andreessen. I'm sure Dr. Mann and myself will have comments about rebates when we get to those bills, but you said it almost better than I could have. I think they're a perverse incentive created by pharmaceutical manufacturers to keep outdated and expensive drugs on the formularies. With that, we're done with the testifiers for 1806 as amended. Are there questions or comments from the committee on the bill? Senator Latz.
Thank you, Mr. Chairman. And I don't know if this, maybe it's a question starts for Senator Mann. Is there any requirement in existing law or in the bill that sets a minimum notice period if there's going to be a change in the formulary? I mean, the short version that I've read says they can't change except when the calendar year ends. But what if someone goes in a week before the calendar year ends and they're told that's when they find out that there's going to be a change in 2 weeks or a week or whatever it is. And maybe it's not enough notice for them to be able to make the adjustments. Or maybe if they got an open enrollment period and they got to make changes then to health plans, they won't have information about any changes in formulary that they would need in order to make intelligent, informed decisions about what health plan to go with in the open enrollment period. Any of that accounted for in existing law or in the bill that we have here?
Senator Mann,
Mr. Chair, are you talking about the patient knowing this information ahead of
Yeah,
time?
yes.
Senator Mann.
So no, so the plan can change the formulary without giving notice to the patient in current law.
Senator Latz.
Yeah. So, Mr. Chairman, Senator Mann, the bill that's proposed before us doesn't make any changes in that regard?
Senator Mann.
Mr. Chair, correct.
Senator Latz.
Mr. Chairman, Senator Mann, I mean, I support what you're trying to do here, but it seems to me that might be another fix that would be pretty important. If the goal is to make sure people aren't surprised about changes in formulary, if there are going to be changes in the formulary, it seems to me people need to know far enough in advance that they can make the adjustments and however they're going to. Go back to the doctor, get another prescription for an alternate, make intelligent, informed decisions about open enrollment periods and what plans are going to cover them, and those kinds of things. I don't know if it's something that could or should fit into this bill here in this process, but I mean, you know a lot more about the system than I do, so I'm just kind of raising the issue, hoping maybe you can figure out a way to address that as well. Mr. Chairman, I did have another question also.
Senator Latz.
And Mr. Selwood raised this question. I guess I don't know the details here, but he asked for biologics to be a part of the process. Sounds like biologics are a different category of drugs that are not rated as interchangeable. Correct me if I'm wrong on that. Are biologics the kind of a drug where if they are substituted, they could result in less efficacy in treating the condition that the prescription is for?
Senator Mann.
Mr. Chair, so I think he was talking about biosimilars.
Okay.
And in this case, we were having this conversation and we're kind of working on it. The medications that he was talking about could potentially be substituted. The only concern that I have and the reason why it wasn't changed in this bill today was because it would potentially require another doctor's visit for a new prescription, and that's what we're trying to avoid in this bill.
Mr. Selwood, any comments?
Nothing to add to that.
Okay. Senator Latz.
So how do we fix that? We've identified another concern here that maybe could be addressed somewhere in the process. Maybe, is there a way to solve that as this bill's moving through, or is that for another day, different conversation?
Senator Mann, I can let you respond, but I guess I'll respond with a little medical experience of my own. Is just that the biologic realm, you know, these are very complicated medications prescribed by specialists. The production of biosimilars has some discussion around it, specifically to your concern that are they identical or are they equally efficacious as this biologic that you've created? And I think Senator Mann's right that often if you're going to substitute out a biologic, a very sophisticated medication for a biosimilar, it may require a physician's visit to sort of approve that. Would that be your comments as well, Dr. Mann?
Exactly, Mr. Chair.
Yeah.
So, Mr. Chairman, maybe that brings us back to my first question, which is if a patient has enough notice that there's going to be a change in the formulary, then they would have time to make an appointment, hopefully, with their physician to see if a biosimilar that might be coming or available on that formulary would be an alternate that they could use rather than changing to some completely different medication or changing health plans to find the formulary that covers what they want covered. So maybe notice is a solution here as well. Just throwing that out there for the.
It does sound, the notification thing sounds like a valid concern for this committee. It does seem like maybe it's a bill of its own that we want to generate, so I think it would take some study. Appreciate you bringing it to the committee's attention. Other questions or comments from the committee on 1806? The motion is Senator Wickland.
Thank you, Mr. Chair. I just wanted to say I appreciate your bringing the bill forward, and I appreciate that work has gone on over the last couple of years trying to refine this so that it is something that we could implement. And, you know, I look forward to having the discussion in HHS to understand more about, you know, how it would work and if we could make this change happen and see the fiscal note. I just it just seems like the burden has gotten to be so much on the patient, and we need to find ways to make that balance go back. I think it's out of balance, and patients are being asked to do so much more. I've had constituents over the years contact me about their either themselves or loved ones that are on a medication that's working, and then they're forced to change, and it just it doesn't seem like a reasonable process right now. So thanks for working on it.
Motion is Senator Wickland's that Senate File 1806 is amended, be recommended to pass and referred to the Committee on Health and Human Services. All those in favor say aye. Aye. Opposed? Motion is adopted. Senator Mann, Senate File 1876 is in front of us.
Thank you, Mr. Chair. 1876 requires that health carriers include a lower cost drug in their formularies. So what's happening today is that the pharmaceutical chain has become a rather perverted, convoluted chain of events that significantly raise the prices of medications for patients, leaving us with oftentimes unaffordable options, while the manufacturers and the PBMs take home record high profits. So to break down a very small piece of this chain, when faced with the choice of a high-priced, high-rebate version of a drug and the low-priced, low-rebate version of the same drug, like a generic, the health plan or the PBM will always choose the high-priced, high-rebate version of the drug to maximize the rebates that they receive. The result in many cases is that the patient will pay more for the drug than the plan pays for the drug. And the result in high costs of the drug at the pharmacy counter means that many patients cannot afford to buy the drugs that they need and are left without a cheaper option, even though cheaper options exist. Now, the way that health insurance is supposed to work is that the healthy subsidize care for the sick, but in this case, the sick are subsidizing care of the healthy. The other problem is that if you are a generic or biosimilar drug company and you want to enter the market with a lower cost drug, the only way for you to get onto a PBM or plan formulary is for you to raise your price so that you can afford a larger rebate. So again, we're trying to infuse with 876 competition at the level of where the manufacturer interacts with the PBM and the plan so that they can have the lowest price get put on the formulary as well as whatever other medication they want to put on the formulary. They can still get all their other drugs on the formulary, but they also have to have the lowest price option available as well. That's it.
Senator Frentz offers the A2 as an author's amendment. All those in favor say aye. Aye. Opposed? We will go to your testifiers. Michelle Crimmins and Joe Selwood. Ms. Crimmins, welcome to the committee. Please introduce yourself and proceed.
Thank you. Good afternoon, Chair Klein, members of the Senate Committee on Commerce and Consumer Protection. My name is Michelle Crimmins, and I'm the Government Affairs Principal and Registered Lobbyist for Prime Therapeutics. We're a pharmacy benefit manager operating and headquartered out of the state of Minnesota. Prime helps people get the medicine that they need to feel better and live well by managing pharmacy benefits for health plans, employers, and governments, programs including Medicare and Medicaid. Our business model focuses on purpose beyond profits. We are not publicly traded. We're not owned by a private equity firm. And because of that, our primary motivation is not to maximize profits. It is to do the right thing. My testimony is in opposition to SF 1876 because it will have the unintended consequence of raising the cost of prescription drugs. And I think we can all agree that prescription drugs currently are unaffordable for everyone. 1876 sets formulary placement requirements for generic drugs and biosimilars in an effort to increase adoption of generic drugs and biosimilar drugs. And while we agree with the intent behind the bill, the restrictions placed on formulary design will increase, not lower the cost of drugs.
Today, about 90% of all prescription drugs dispensed are generic drugs. It's a very high adoption rate, 90%. And the savings generated by the high adoption rate is clear. According to the IMS Health Institute, generic drugs saved the U.S. healthcare system nearly $2.2 trillion. So we believe those numbers are clear. There's been a high adoption rate of generic drugs, biosimilars, and formulary design is a high part of why that is the case. And thank you for allowing me to testify today. I welcome any questions.
Thank you, Ms. Crimmins. Mr. Selwood, welcome back.
Thank you, Mr. Chair. Members of the committee, again, Joe Selwood testifying on behalf of the Association for Accessible Medicines. And I do want to highlight on what was just said that generic and biosimilar medicines do make up for 90% of drugs dispensed, but only 13% of the cost. I want to thank Senator Mann for the amendment that addresses some of the concerns that we raised in subdivisions 2 and 3 by removing the requirement to compare wholesale acquisition costs at the molecule level. This amendment clarifies that the competition between manufacturers that results in lower costs for patients will continue without causing significant shortages in the market. AAM is continuing to work on suggestions regarding the biologic and biosimilar provisions in subdivision 2C and D and subdivision 3. This is a more complicated marketplace due to the differences between biologic and small molecule marketplace. AAM is committed to working with Senator Mann so patients have access to lower cost biosimilars. AAM also looks forward to working on the provisions in subdivision 4, which require PBMs and health carriers to give preferential treatment to the specific drug with the lowest out-of-pocket cost to patients. However, this approach doesn't reflect how formularies and patient costs are established. The out-of-pocket costs are determined by where on the formulary the drug is placed. So you can't determine the out-of-pocket cost until each drug is placed on a specific tier of the formulary. Again, AAM will continue to work with the author as the bill progresses. Thank you, and I'm happy to answer any questions.
Thank you, Mr. Selwood. Member questions or comments on the bill? Senator Mann, Senator Wickland moves that Senate File 1876 is amended, be recommended to pass, and moved to the Committee on Health and Human Services. All those in favor say aye. Aye. Opposed? Motion is adopted. Senator Mann, 1877 is in front of the committee.
Thank you, Mr. Chair. So 1877 is the last piece of today's puzzle. It is the point of sale bill that will require the PBMs to pass down any rebates to the patient at the point of sale. So between 1877 and 1876, we are tackling the high price of drugs from two angles. One is requiring a low price to be on the formulary, and two is that that can't happen, then we want those rebates to be passed on to the patient. The advantage of this approach is that PBMs already have done all the programming to make this possible. Other states are already doing this, so we know that it works. And then we do have an amendment, Mr. Chair, that would say that if you have a plan that already has a low copay, then you don't even have to do this rebate pass down because you are already offering your clients or the patients savings in the way of a low copay. So low copay, rebate, or low formulary, pick your poison to bring down the price of drugs.
Senator Rest offers the A1 as an author's amendment. All those in favor say aye. Aye. Opposed? Ms. Michelle Mack. Welcome to the committee. Please introduce yourself. Proceed.
Good afternoon, Chair Klein and members of the committee. My name is Michelle Mack, and I'm a Senior Director of State Affairs with the Pharmaceutical Care Management Association, otherwise known as PCMA. Thank you for the opportunity to provide testimony to Senate File Senate File 1877. PCMA is the National Trade Association representing America's pharmacy benefit managers, otherwise known as PBMs, which administer prescription drug plans for more than 289 million Americans with health coverage provided through employers, health insurance plans, labor unions, Medicaid, Medicare, federal employee health benefit programs, and other public programs. PCMA opposes Senate File 1877 because it will increase healthcare costs by requiring health plans to forfeit the savings achieved through rebates that have been negotiated with drug manufacturers and that help reduce premiums for all members and instead provide point-of-sale rebates to a select group of health plan beneficiaries who are prescribed a limited number of brand name drugs. In year one alone, PCMA has analyzed this legislation to lead to almost a $135 million increase in excess drug spending and over $1.6 billion over the next 10 years in the state of Minnesota. Pharmaceutical rebates are price concessions negotiated by PBMs that reduce the net cost of providing prescription drug coverage. PBMs share the negotiated rebates in whole or in part with the plan sponsors. Employers, more specifically smaller employers, may include a contract provision for their PBM to retain a portion of their rebates as compensation for their services. The plan sponsor typically uses the value of rebates to reduce costs to plan members or to enhance their benefits. In the Medicare market, 99.6% of rebates are passed back, and in the commercial market, 91% of the rebates are passed on to plan sponsors. Employers have the option to apply estimated rebate amounts at point of sale, but most of them do not. Plan members are very sensitive to premium costs, and point of sale rebates are correlated with higher premiums. Most rebated drugs already have lower cost sharing based on their being preferred drugs under a patient's coverage. The Centers for Medicare and Medicaid, otherwise known as CMS, Office of the Actuary, found that if Medicare plans were required to apply rebates at the point of sale, manufacturers would offer lower rebates, raising the cost of drugs. CMS estimated that the point of sale rebates would cause a 15% decline in rebates. Rebates are the primary way that healthcare payers reduce the net cost of drugs for plan members. While not a perfect system, when there is competition available, rebates can save patients a significant amount of money. Point-of-sale rebates, on the other hand, are likely to result in fewer price concessions by manufacturers, tend to increase premiums, and are likely to result in higher costs for plan members. We do have some questions as to which market segment this bill applies to, such as medical assistance, the Minnesota State Employee Group Insurance Plan, and self-insured plans. Finally, PCMA believes that Senate File 1877, by shifting rebate amounts to individual enrollees instead of applying them to the entire plan, will likely increase premiums for most enrollees. This bill also does not address the underlying epidemic of high drug prices. And finally, it eliminates plan design choice for purchasers. It is for these reasons that we are opposed to Senate File 1877, but we are happy to work with Senator Mann relative to this bill. Thank you for your time and consideration, and I'll be happy to stand for any questions.
Thank you, Ms. Mack. Senator Mann, I remember when Senator Carla Nelson carried this bill through the Senate, and we heard it there, and I can't agree more that if drug manufacturers are going to offer rebates to try to keep their drugs on formularies, wouldn't it be great if we could get those rebates into the hand of Minnesotans who are paying for their medications? So appreciate the bill, appreciate the amendment. Other comments or questions from the committee? Senator France.
Thank you, Mr. Chair, and thank you, Senator Mann. Allow me this support, first of all, for your bill, and then to ask this question in the Commerce Committee. What do we need these rebates for? For whose benefit are the rebates? And how come we never get any emails from any consumers, the people actually paying the bill, asking for more rebates?
Senator Mann.
Mr. Chair, well, currently, the rebates do not benefit the consumers, and they don't know that they exist. So they benefit the plans, they benefit the PBMs, and that's why PBMs take home billions of dollars in profits. So consumers don't ask for them because they don't know that they're there. I will also say that this is not revolutionary language. Connecticut, West Virginia, Arkansas, Maine, they've all done this before, asked for the rebates for the patient. There was a Millman study that was recently done looking at what happened in Arkansas, and lo and behold, the premiums did not increase. I think that any time that we pass a bill that says give the money to the patient so that the patient can save money versus pharmaceutical companies and PBMs taking home billions of dollars in profits, everyone says, oh, we can't do that because we can't make drugs anymore then. If we cut our profit margins, then premiums will go up and patients won't be able to afford healthcare. Patients cannot afford healthcare today. So that argument is so trite, it's unbelievable. But we have the studies to back up that it's just plain false. So the reason why they don't ask for it is because they don't know it exists. And currently it benefits the big companies and not the people.
Senator Friend?
Thank you, Mr. Chair. Thank you, Senator Mann.
Senator Green?
Thank you, Mr. Chair. Senator Mann, one of your testifiers testified that he gave the example that one drug might cost $100, the other one might cost $140, and the $140 gives the rebate. And so with the rebate, then the more expensive drug would become the cheaper drug. And without the rebate, then you'd be actually paying $10 more. And so how do you respond to that? Is that you don't take that into consideration? Is that not valid in your opinion?
Senator Mann?
Mr. Chair, so I think part of that was used on the previous bill. But if you're saying that the drug has a larger rebate and the drug is now more expensive, then that patient at the point of sale will get a larger rebate, meaning that their drug will be cheaper.
Mr. Chair.
Senator Green, and the only thing I would add to that is that if you are the manufacturer of the more expensive drug, of the $140 drug, and you see that somebody's coming in with a generic that costs $40 less, the way you keep your drug on the formulary, your obsolete drug that could be easily replaced by a cheaper and equally effective generic, is by offering these rebates to PBMs to keep it on the formulary. So you perversely, discourage innovation, discourage lowering prices, and that's my take on it. But Senator Green, sorry.
Well, thank you. And so, I think we're assuming then that every consumer that comes in is going to be able to ask for the drug. And my question, and I don't know this, but my question is those that are offering the drug are going to take the cheaper drug. If they're not going to get the rebate, they're going to offer the $100 drug instead of the $141 that would have offered them the rebate. So to them, the $100 drug is cheaper, which will result in more cost to the consumer, would it not? How does the consumer know to ask for the drug that has the rebate? Can you clue me in on that?
Senator Mann.
Mr. Chair, I'm not sure I fully understand the question, but there's 2 points, I think. One is that we think that a consumer has the opportunity to show up at a counter and ask for a drug, and this is not the case.
Correct.
Right? They are prescribed a medication, whether it's brand or generic. They don't have a choice. So I think that's probably the biggest issue here, is that we think consumers in the healthcare space have more choice than they actually have. And we have this conversation when it comes to like surgery. When a patient has an appendicitis, well, why can't they just go find the cheapest place to have their appendix taken out? Healthcare doesn't work that way. It's not a supply and demand kind of thing where we're buying clothing. Same thing with medications. So I'm not sure that that argument holds water in this particular case.
Senator Green.
Mr. Chair, I think you just made my point. The only drug that's going to be offered to the consumer is the one that doesn't have the rebate, because that's the one they're going to be offering because it's cheaper on the top, on the back end. But so I don't think that the two conversations are melding here. I see a problem with this, and I'm listening to some of the other testimony, and I do think it will obviously raise insurance costs. So the consumer is going to be paying for that drug either in higher premiums or the fact that the cheaper drug before the rebate is going to be the one that's offered. So.
Senator Dames.
Well, thank you, Mr. Chair. If you have this rebate going back to the consumer when they request it, there's going to be a lot of bookkeeping and a lot of tracking that's going to be needed. The pharmacist is going to have to decide if that person should be getting the rebate or should not be getting the rebate. The the drug companies are gonna have to decide which ones did get the rebates and who didn't. And then we're gonna need people to go out and to survey all these folks and make sure that nobody was taking rebates they shouldn't have, or were taking rebates they should have. Who's gonna pay for all that cost?
Senator Mann.
Mr. Chair, so again, in all the other states that have done this, they did not see an increase in costs, not only in administrative costs, but also in premiums.
Senator Dames.
Follow up, Mr. Chair. You're referring to other states, and I don't know how much research you've done to see how those other states operate specifically the same as Minnesota. If they don't operate the same as Minnesota, what other states do really don't make much difference. In Minnesota, you're going to have those costs. Who's going to pay for those?
Before I turn it over to Senator Mann, I'll just say that presumably our fiscal note will account for those costs. It's been represented to us that they don't exist, but Senator Mann.
Mr. Chair, so generally these things are done at a pharmacy level. And again, we will see those on a fiscal note, Senator.
Senator Dames.
Well, thank you for your answer, Senator Mann. So it sounds to me like our pharmacies are the ones that are going to be on hook to do all of this work and keep track of everything. And in rural Minnesota, it's tough times to find pharmacies, and so now we're going to load them down with a bunch of extra work. Thank you, Mr. Chair.
Further questions or comments from the committee? The motion is Senator Wickland's that Senate File 1877 is amended, be recommended to pass and referred to the Committee on Health and Human Services. All those in favor, say aye. Aye. Opposed? Motion is adopted. Senator Pappas is on her way. Brief recess. come back to order. Welcome to the committee, Senator Pappas. We are going to take Senate File 1481 off of the table. We don't need to have testifiers. We've had testifiers on this. We can have discussion. I gather you've worked with Senator Rasmussen on an author's amendment. This is the first stop, so this would be considered an author's amendment.
Thank you, Mr. Chairman. That's the A1 amendment, and I really appreciate the conversation that I had last week, I think it was, with committee members, and Senator Rasmussen came up with a suggestion to just for the Pollution Control Agency to send notices to retailers, and the Minnesota Pollution Control Agency also prefers that approach. So we're happy to go in that direction, and I believe then, Mr. Chairman, I assume we'd have to go to the Environment Committee from here.
Senator Pappas, first let's get the A1 on board. Senator Frentz offers the A1 as an author's amendment. All in favor say aye. Aye. Opposed? And we don't need testifiers. Is there any discussion? Senator Rest.
Thank you, Mr. Chairman. I noticed the blank with the penalties. Even if you aren't prepared to fill in that blank right now, do you have any idea what you might be asking for?
Senator Pappas.
Mr. Chairman and Senator Rest, I think I would consult with the Pollution Control Agency to see what their penalty range is. I would imagine it'd be in the range of $500 to $1,000, something like that.
Okay, thank you.
Senator
But
Rest.
I'll consult with them.
Further discussion from the committee on the bill as amended. Thank you for your work on the bill. Sorry it took 2 trips to get it through here.
It's a better bill.
Senator Rasmussen offers that Senate File 1481 is amended, be recommended to pass and referred to the Committee on Environment, Climate, and Legacy. All those in favor say aye. Aye. Opposed? Motion is adopted. Members,
Thank you.
committee
Thank
is
you, Mr.
adjourned.
Chairman.